Good morning, everyone, and welcome to the Millbank Memorial Fund Multi-State Collaborative Topical Webinar for May 25th, 2017. Today we have an exploration of one of the essential underpinnings of advanced primary care and an explicit function of the Comprehensive Primary Care Plus project. Diane Bechel-Marriott of the University of Michigan School of Public Health and the manager of the Michigan Primary Care Transformation Project will be presenting an overview of Michigan's comprehensive patient and caregiver and family engagement activities. In addition, we have with us Ann Greiner, the President and Chief Executive Officer of the Patient-Centered Primary Care Collaborative, the PCPCC. She will be connecting this cutting-edge work based in Michigan to the national activities from the vantage point of her nationally based organization. Many, many thanks to both of them for sharing their formidable expertise and experience today. I'd like to hand over the mic to my friend and colleague, Diane Bechel-Marriott.
Hi, Lisa. Thank you so much for the opportunity to talk together about incorporation of the patient and family voice into co-design of primary care transformation projects and the national effort to improve care. Here today to focus on the work and provide as an example of one of the many ways that care is being transformed through the incorporation of the patient and family voice, the work that we've experienced in Michigan through our 5-year Michigan Primary Care Transformation Project demonstration. And in the project, we thought it would be helpful to link our example of incorporation of patient voice with current state and the landscape of what practices are facing now, particularly with Comprehensive Primary Care Plus or CPC Plus initiative. So today we're here to share 3 main discussion points. The first is to place the incorporation of the Patient and Family Advisory Council work and incorporation of patient and family voice and engagement into CPC Plus, thinking about the Patient and Family Council or PFAC requirement in that exciting program, which is now 14 regions. Second, to provide some examples from the 5-year project in Michigan. And third, to think together about implications for the multi-state partnership and other states who embark in this effort regarding primary care transformation. First, linking the important topic to the current landscape in terms of CPC Plus. One of the main functions that CPC Plus practices are required to fulfill, and that it really is a core domain of the program, is one on patient and family caregiver engagement. CPC Plus emphasizes the incorporation of patient and family caregiver preferences, values, and needs in care, and specifically includes a requirement to organize and operate a patient and family advisory council, really focusing on that role to patient-centered, on the role to patient-centeredness. Also incorporating some patient and family engagement change concepts, including encouraging and engaging patients and caregivers, not only to incorporate improvement and incorporate the patient voice in their own course of treatment, but also in the broader array of co-design so that we together increasingly architect a more patient-centered infrastructure. Both Track 1 and Track 2 practices have a requirement to convene a Patient and Family Advisory Council at least once in the remaining calendar year of 2017, and integrate recommendations into care. We anticipate that this is kind of an initial starting year opportunity, and really, of course, the opportunity for more frequent patient and family advisory council input seems only right in future years. In addition to the CPC Plus requirement and ongoing transformation, in Michigan over the past 5 years, through our MiPCT, Multipayer Advanced Primary Care demonstration, although it was not a required element, we offered the opportunity for those who were ready and willing for our practice panel of 350 practices to also initiate patient and family advisory councils, kind of as earlier pioneers of this work, and incorporated a program level patient and family council. We'll talk a little bit about that experience here. And we start by a favorite quote that I incorporated at the start of my doctoral dissertation, and it was a Henry Ferrari quote. The roles of the patient and the doctor in quality assessment are much like that of the pig and the hen in the making of breakfast. The hen is involved, but the pig is committed. It's the partnership and the trusted relationships between clinicians, caregivers, and patients is such a sacred one. But at the end of the day, it's the patient's activities of daily life. It's the patient's health status that really is at play, and what a strong commitment from this. When we look at the work in Michigan, we founded it on a number of things that we were learning from healthcare informatics, healthcare communication and design, and the rich literature on the user experience, and tried to incorporate the cornerstones that we saw in much of the literature. Judy Hibbert's got great work on this, Shoshana Shafar, or so many others, in terms of repeated messaging, trying to deliver information that is user-friendly at a teachable moment, language that is straightforward, language with focus groups in advance, realizing that this is not a once and done, but rather a multi-year and a multi-phased approach, and really providing preparation, context, and user support in terms of the practice perspective and of ways to benefit from the incorporation of patient voice, as well as providing something back to the patient from the provision of that information. And certainly all on this webinar would agree that there are many reasons to incorporate the patient and family and caregivers to a greater extent in engagement. Not only embracing the important concept of the fourth, or bringing joy in terms of providers, but also in incorporating a more user-friendly patient experience, and one that brings greater value to the system at large. To begin our work, because this aspect of our program was voluntary and not mandatory, we had 350 practices, but it was a coalition of 10 practices that were the willing and able that engaged in this voice of the patient initiative with us. We really had to, at a project-wide level and at a practice level, establish a cause to be, a why would one incorporate in program design. And certainly it's most straightforward to build the case, and there are more opportunities and alternatives to the traditional primary care approach in terms of disruptive innovations. There are some problems and some important challenges and issues that we can really only tackle with incorporation of the patient voice. And also that building these things early provides not only a competitive advantage, but certainly is the right thing to do. in terms of better discerning those benefits of advisory councils and advisors to practices, we really focused around the potential improvement on challenge areas to practices from obtaining this kind of third perspective. We also provided some tools to practices and to our program level approach at large that we found seemed to be helpful in terms of helping practices and helping the program at large realize that we don't need to recreate or do this work alone, that we tried as much as we could to provide a toolkit that others could model from, including the foundational aspect of what is the role or what does a patient and family advisory council do, and how can it be beneficial. And we really focused on not only the incorporation of nothing about me without me in terms of incorporating a more user-friendly system, also obtaining ideas and testing potential solutions that would not have been internally derived, certainly decreasing barriers to patient engagement, and the continued work toward sharing of best practices. We also found that it was a great opportunity for incorporation of input on PCMH transformation and quality improvement activities, particularly interestingly around measure improvement. Also in provision of tools, there was certainly some work that we did in providing tools to practices and to the program regarding the kinds of patients or family members or caregivers who might best embrace this role. And we found a special goodness in looking for people who would be comfortable in speaking publicly with candor, able to use their own experience constructively, and importantly, able to see beyond their own experience, really to the focus on the community. And as with everything, the ability to listen, hear different opinions, and embrace the community of ideas was certainly key. We also identified some best practices to support our patient and family caregiver members, including that development of personal relationships among the council, kind of offering an approach that would offer training to the advisors and to the staff in the office who were convening the advisors in a joint fashion, offering committee members and council members the opportunity to connect and provide opportunities for input. And of course, as with anything, providing an opportunity for orientation, because this advisory role is new not only to many practices, but also to patients, families, and caregivers. As we worked in the Michigan Primary Care Transformation Project, there were a number of ways that we built patient voice in using these tools. The first was a program-level patient advisory council, and these were 7 members who were appointed by their physician organizations using those kind of appointment criteria. And they came from the array of the 5 plans that participated in our Multipayer, common clinical and financial work in primary care transformation. And they spanned Medicare members, Medicaid members, commercial members. It was just a great opportunity to take potential change ideas and work on program development and building for a more patient-friendly approach in terms of what IHI describes as program co-design. The second way that patient voice was built in was providing an opportunity for patients and caregivers, often from these program level and practice level councils, to share their story at our functions and venues when we convened practices. That included patients. We had we had a patient who just did a great job, who led the Patient and Family Advisory Council, Carrie Fannin, who at our first summit delivered the keynote. And it's just such a grounding experience to hear that patient story as a foundation for those kinds of summits and symposiums. There was also work that we did in blending and creating relationships between the Medicaid health plan care managers and our care managers in the MiPCT 300 and the 350 MiPCT primary care offices, and in building those relationships in terms of optimizing what could be done at the plan level versus what could be done at the practice level in terms of coordination and synergy for the benefit of the patient. We started and kicked off with the reason that we're doing this work, which was a sharing of a Medicaid member in terms of her experience with joint case management at the plan level and care management at the practice level. We also partnered with the Institute for Patient and Family-Centered Care in the Greater Detroit Area Health Council to jointly offer the Coalition of the Ready and Willing, the 10 practices that step forward, in-depth training for them to kick off their own practice-level patient and family advisory councils. And some of our practices and physician organizations also worked with kind of e-council input, having a panel of patients that they communicated with electronically in terms of obtaining feedback. And also we tried as much as possible to integrate opportunities for our patients to take advantage. The 1.2 million patients in Michigan served by the 350 practices of the patient training regarding self-management, like the Stanford self-management programs. In Michigan, we call it Michigan Pathways, and opportunities for folks to step forward and volunteer as facilitators. And several of us were trained in diabetes and chronic management in terms of volunteer opportunities. First, a very brief run through of a deeper dive on the approach to program level patient and family advisory council in the MiPCT. This is just one example of one of the actual agendas that we used. But this slide provides an opportunity to look at some of the discernible issues taken to the Patient and Family Advisory Council, and they included opportunities when we thought about additional questions that we should incorporate in our CAP-CG survey. The construct of those additional questions was taken to the Patient and Family Advisory Council kind of as a psychometric in language testing of questions, and we changed some things as a result of their feedback. We also shared with them the results at a program level of the aggregate finding of our CAP-CG, or our patient experience findings. And there are certainly some, it's certainly always interesting to explore those question by question responses within the domains. When we introduced, as we transition from the 5-year demonstration to supporting the CPC Plus and our state SIM PCMH program, and in that program, SIM PCMH also incorporated the role of community health workers. It's this group that we took that concept to first in terms of an orientation and a presentation by community health workers who were existent on the west side of the state. And it was really helpful to us that all the patient and family members who participated in our program-wide council had experience, were not only from our practices and from our payers, but also had direct experience with care management servicing within the practice. So we talked about program level patient and family advisory council work. Now we'll transition to that practice level work. Coalition of the 10 willing and able. And we used a train the trainer approach so that we could benefit along with the training from the Institute for Patient and Family Centered Care that we embarked upon in collaboration with these 10 practices. And then we could spread the learning to other practices. And this I think will become very helpful as we approach the CPC, the 5 years of the CPC Plus, and the allowing the practices to meet the requirement of patient and family councils, and not just meet the requirement, but grow from it and benefit. After we recruited for the coalition of the 10 willing and able practices, we did a train the trainer, which was that co-sponsored effort with the Institute for Patient and Family Centered Care in a local coalition, the Greater Detroit Area Health Council. We then coached the practices with coaching calls as they kicked off their patient and family advisory councils at the practice level, realizing that this was, again, new work to them, and then we wanted to stay tuned to additional support that they needed as they were really volunteering to be pioneers in this work. And then we conducted a voice of the patient kind of session with them, celebrating their success. And I'm just sharing a bit from those sessions. I mean, it was, we talked about the importance of transformation, but this slide tile captures it best. Change is good, and you go first. And these 10 willing and able certainly did. But again, at this training, we had not only the advisors from the practices in terms of the patients and family caregivers who had been involved, but we also had practice representatives, including physicians. Some of the practices also incorporated their physicians, which was a great opportunity to work together. We learned many things, including starting to sustain a patient and family council advisory approach requires work, and there can be a temptation to kind of give up too soon, but that the value of these things builds over time, and the more that practices understand and know that from the get-go, they're building for the future rather than trying to paddle faster. We also looked for opportunities for quick wins where the practice would benefit from specific input on advisors if they asked the right questions in terms of overcoming a challenge area for the practice, whether it's a point at which that they're stuck in metric improvement, or looking at how to better array patient flow. And we met on Halloween, and the trainers also brought some Halloween apparatuses. You'll see Hawaiian leis and a blue wig in this, but at any rate, it's an example. It's a pictorial from our training days in terms of one of the practices. And here we see the physician, we see the advisors, we see some front office staff working together on their approach to patient and family advisory council work. It started with a kind of infographic design of what they wanted this to look like in their practice. And we're pleased to say that some of those practices, we've stayed in touch and continue to operate their own patient and family advisory councils. Given this, just wanted to transition to implications that this has for our work together for CPC Plus, Milbank Partners, and the greater good over the next 5 years. Certainly, as we look at the requirement for patient and family advisory councils in 2017 and beyond in CPC Plus, and the whole opportunity to partner or integrate with the regional learning contractors on this important initiative. It certainly seems something to explore in terms of regions, also assessing whether this idea of supplemental training might be helpful. Encouraging practices to think of patient and family advisory councils not as a way to meet a requirement, but as a benefit that can help them in the long term. And one of the aspects of how we do business in this new environment. And again, that idea of establishing quick wins is awfully important. And we learned it was also quite important to share what we did, what was done at the practice level, at the program level, with patient and family advisor input back to understanding of change that was received. And we transition to Ann's remarks and Lisa's remarks with some free gifts without purchase. There are several tools that we found in national literature that were helpful in framing this and that might be helpful to CPC Plus practices and regions as they embark in the work. The Institute of Medicine had done some really nice work on the incorporation of the patient voice in transforming healthcare scheduling and access. We provide that. Additionally, some really interesting work that Deloitte did on how we can better understand the ties between use of the healthcare system and level of engagement with a consumer profiling approach in terms of information use, likelihood to want to drive their own decisions, and how that they're raised generationally over time. And then also some work in the National Health Service regarding user experience and experience-based design as it relates to healthcare and primary care. And finally, some U.S. government work that's quite interested in thinking about the array of user experience and connecting user experience at a national level in that research into patient experience and into our journey together. With that, we're thankful for the opportunity to discuss this and eager to hear about Ann and Lisa's thoughts.
Thank you so much, Diane. That was a wonderful presentation. I'd like to turn the mic over to our colleague from the PCPCC, Ann Greiner.
Thank you so much, Lisa. I really appreciate the opportunity to be here today. And Diane, wonderful presentation, and it's so exciting to hear about your journey. And I really want to applaud you all for making patient and family engagement, this element of your package to transform clinical care. And it was those courageous 10 practices that really were pioneers, and I think we can all learn from what they did and your journey over the last 5 years. When I reflect on where we've come, things are moving really rapidly. I recall when Don Berwick became the CMS administrator, there really was not this kind of activity at all at CMS. Certainly, CMMI was, just getting started. Don was the CMS administrator in 2010 and 2011. And so, 2017, if you think about that, things have moved now quite quickly, where patient and family engagement is a requirement now in CPC Plus, and this whole notion is really getting embedded across the agency. So that's very exciting. And I would also reflect that it first really began in hospitals, and now is rolling out in the ambulatory setting. And I think that the role of the government has really given it this whole notion of patient family engagement a boost. So I think it's exciting. When things are a requirement, we want to make sure that there is that excitement about them, and it doesn't feel like it's a check the box enterprise. And I also want to say before I reflect about the PCPCC's work in this area that I really want to have a major shout out to Michigan as a state, because they have done so much in the patient-centered medical home and the arena of transforming ambulatory practices. In fact, Michigan is featured in the PCPCC's evidence report for 2017 that will be coming out next month. And it is a state that has been so committed to the patient-centered medical home. And in fact, one of its plans, Blue Cross Blue Shield, has probably the largest, not probably, it has the largest private sector initiative of longest standing related to the patient-centered medical home. And now they're seeing all kinds of results. So just a little shout out to Michigan for their leadership in this area. We here at the PCPCC really see patient-family engagement as an absolutely essential element to use in transforming practices. And I think that the evidence really backs that up. You and Diane alluded to some of this, practices that are leveraging patient and family engagement see improved patient outcomes and also more satisfying relationships with their patients. And that's really no surprise. We've just developed new shared principles for high-performing primary care. And patient and family-centered care is the first principle. There are 7 principles, but we see that as, in the hierarchy, the most important principle, if you will. And if you are familiar with the PCPCC's work, when the organization first got started in 2007, we had the joint principles for the patient-centered medical home. And they were really focused on that model. And 10 years later, we're considering an array of different models to advance primary care, and have developed these new principles with the input of over 300 organizations from every stakeholder group in healthcare. And they reflect how primary care has evolved. And I think if you read the 2007 against the 2017, there's an evolution in many areas, but absolutely in the patient and family-centered area. You see much more sophistication in the notion that patients and families should be involved in the design and redesign of practices, figuring out how to change, daily operations to make practices more responsive to patient needs and preferences, and also really in evaluating care delivery and experience of care. And so that really is an evolution over a 10-year period that I think we can all feel really good about. The Patient-Centered Primary Care Collaborative is also involved in a CMMI grant, the Center for Medicare and Medicaid Innovation Grant, which is called Transforming Clinical Practice Initiative, the TCPI. I hate to introduce more acronyms, but there you have it. And our role is as a support and alignment network. And I think this is also a new concept for CMMI, and I really take my hat off to them, because the whole idea is that things that the public sector is they're innovating and they're working with practices. What can be done to try to further align with the private sector? And so our role in that grant, TCPI, is patient and family engagement. And there are about 100,000 practices involved in that grant. And we are working with the Institute for Patient and Family Centered Care, which Diane also worked with. So good partners, Diane, and Plaintree and the Y on patient and family engagement with these 100,000 practices. Many of the tools that we've developed over the last couple of years are on our website, and we'll make sure that everybody on this webinar gets a link to that website. And very helpful tools about how to set up and resources, how to set up a patient and family advisory council, how to select patient and family advisors, tools related to how do you address health literacy, because if you're going to be engaging patients and families, may need to do some work to enhance patient literacy with respect to health. How do we work towards activating patients? So there's tools related to patient activation. And also, I think what we're all trying to achieve is how do we help patients and families and clinicians work together with respect to decisions that are made in the clinical encounter. So we know that enhanced health literacy, patients that are activated, clinicians and patients working together to figure out which pathway with respect to different modalities of care. Those all can lead to patients following through on suggested treatment and their own management of their condition when they are outside of that patient office back at home. It increases patient satisfaction that they're working as a partner with their clinician to achieve restoring themselves to health. And also we know that, in fact, it results in enhanced patient outcomes. One of the other messages with our the practices that we're working with is that this actually also makes good business sense. And we all know from our engagement with other sectors in our economy that are much more customer focused, that the health system has a ways to go. And that if you are understanding what your quote unquote customer or your patient needs are and are responsive to that, you're going to, grow your business. And so we also make that point when we are implementing these tools. We do not yet have data to demonstrate this in TCPI, but the literature suggests that patient and family engagement can improve patient retention and patient satisfaction scores. I think also when we get to the point where we have more patient-reported outcome measures, this kind of engagement will also help clinicians to achieve better results with respect to patient reported outcomes. I think we're really at this critical moment of alignment, and the Michigan work, I think, is a wonderful example. You were involved in a public program. You weren't required to do patient and family engagement, and you did. Now we see practices all across the country doing this. We also know that in the new physician payment program for those that are providing care to Medicare beneficiaries, the MACRA, the Medicare Quality Payment Program is recognizing patient engagement as reportable activity for that payment program, and that's another incident, or excuse me, and it's another example of alignment between, what the public sector is requiring of physicians and what's happening out there in the private sector. I think there are many, many examples across the country, not just patient-centered medical homes, but also ACOs that are incorporating patient and family engagement, and that is counting in public programs. So that's all very, very exciting. I really am so excited to have this opportunity today, and I so appreciate the work that Milbank is doing to help support research and practice redesign and the evolution of primary care to make it more robust and patient-centered. So thanks so much, Lisa and Diane.
Thank you very much, Ann. And I just want to also give a shout out to both of our presenters. Did an excellent job today, and want to direct our participants to our website where you can get access to the slides that Diane presented to us today, as well as information linked to previous webinars and obviously future ones as we move forward. Again, thanks to everyone today, and we'll talk to you all next month.